Please welcome AAP California Chapter 2 Vice President and President-elect, Dr. Grant Chrisman.
Hello, everyone. Thanks for attending the symposium. It's my pleasure to introduce my friend and colleague, Dr. Christopher Russell. Dr. Russell is an associate professor of clinical pediatrics in the Division of Hospital Medicine at Children's Hospital Los Angeles. He completed his undergraduate degree in psychology and biology at Harvard University, his medical degree at Harvard Medical School, and his pediatric residency at the University of California, San Francisco, and his Master of Science in Clinical Biomedical and Translational Investigations from USC. His clinical responsibilities include attending on the pediatric inpatient service at CHLA. His current research focuses on improving the prevention, diagnosis, and treatment of bacterial respiratory tract infections such as pneumonia in children with complex medical conditions. In addition to his research, Dr. Russell works in the CHLA Office of Diversity, Equity, and Inclusion, leading trainings on implicit bias and microaggressions for all CHLA employees and spearheading key health equity initiatives. Outside of his clinical and research responsibilities, Dr. Russell focuses on research mentorship of medical students, pediatric residents, and pediatric hospital medicine fellows, as well as improving representation of underrepresented minorities in medicine throughout the continuum of physician training. Dr. Russell, take it away.
Great. Can you guys hear me all right?
Yep.
Great. Perfect. I'll share my slides. First of all, I really want to thank Grant and Tomas for the kind invitation to present today on this topic that's very important to me. We're going to be talking about addressing bias and microaggressions in the clinical environment. I want to start off by just talking a little bit about some group norms for the next 30 minutes. Talking about microaggressions and racism can be sometimes uncomfortable, and people can put their foot in their mouth. So I wanted to just put some norms, including that we assume positive intent, that when people are asking questions in the chat box, we listen with respect and an open mind, and that we speak respectfully and maintain confidentiality. So things might be said and try to keep it in the room. And finally, just embrace the discomfort. This is a topic that may not be comfortable for many people on the call. By the end of this talk, you should be able to define forms and themes of microaggressions. We're going to illustrate the impact of microaggressions in at least the clinical learning environment. And I'm going to you should be able to describe at least 2 frameworks for interrupting microaggressions in the clinical environment. So first, I'm going to start with talking about microaggressions, defining some key terms and themes. Microaggressions are brief, commonplace statements, actions, or incidents. They're often statements that are indirect, subtle, or unintentional, but these phrases and statements and behaviors do communicate hostile, derogatory, or negative views against members of a marginalized group. Unfortunately, microaggressions and bias are constant and continuous in people of color's lives, and they become cumulative in nature, and they often represent a lifelong burden, and often are continuous reminders of the target's group's second-class status. When we think about microaggressions and think about what goes into them, the microaggressions are really rooted in microaggressions and other forms of racism and bias are often rooted in power differentials and also in indirect or direct assertions of power from one person or group to another. So we can't talk about microaggressions, bias, and racism without talking about power. And Dr. Pamela Hayes is one of the leaders in this field and created what we call the addressing framework, which is a model of cultural influences and their relationship to the social powers of construct. And what she did in her group was take a number of cultural characteristics that are listed on the left, and then really just thought about who in society are the people who are in relative power or influence, and then identifying people who are in less power or influence. I'm not going to go through all of these, but I'll take one example. I'll take age and influence and generational influences. So for example, people who are in relative power in our society are adults, compared to people who are at the extremes of ages, people who are very young, infants, children, adolescents, or those at the extreme older age, our elders. When we think about these different places of relative power versus less power, it helps us to identify where there might be power differentials and where bias, microaggressions might be influenced by these differential powers. So we really need to explicitly identify differences in powers that might make our interactions susceptible to increased risks of microaggressions. And just today, I came across this on one of my colleagues' Facebook pages, this wheel of power and privilege. And it basically takes the slide previously and just illustrates all the different areas where there might be differences in power, and added even a few more, including housing, body size, and mental health, and neurodiversity. And then goes from the center where there's really power to the outside where there's marginalized communities. So this was just a great representation of what was talking about earlier. So as we think about power and we think about microaggressions, which are these brief statements that that display power differentials between two groups, we want to define the people who might be involved in it. First are the targets, which are the people who are the objects of the prejudice or discrimination. We have our allies, who I'm hoping by the end of this talk, everyone will feel more comfortable being an ally. A person who belongs to one of those groups of power, who support those in less power, and really work to eradicate prejudice and discrimination across our community. And then we have bystanders, who are really individuals who sort of get it. They understand that there's racial or other types of bias behaviors in our everyday society or institutional policies and practices, but are sort of on the sidelines. They're not really actively working to change it. So we're going to talk, these are sort of the groups of people who are going to be involved in some of the scenarios that I'll talk about later. And we want to categorize the kind of microaggressions. So there's really three types or categories of microaggressions. And this comes from the work from Dr. Su and his colleagues, who I'll talk about in a few slides. The first one is microassaults, which are really oftentimes conscious statements of microaggressions. And they often, what we call them, is old-fashioned racism. So this is using the term Oriental to describe a person, displaying a Confederate flag, some of the mascots for our sports teams like the Redskins. So these are, that's contrasted with unconscious ones. So sort of micro insults, which are communications that might be nonverbal that convey rudeness or insensitivity. So, an example of this might be saying that I believe that the most qualified person should get the job regardless of race, which makes a suggestion that people who are of a certain race aren't necessarily as qualified as others. The third one is micro invalidations, which are often unconscious as well, that communications that exclude, negate thoughts or feelings or experiences. So when someone brings up an issue that made them uncomfortable, saying, oh, don't be so insensitive, the person didn't mean that, really mean to insult you, is an example of sort of an invalidation of that person's feelings. Dr. Su and his colleagues nearly 15 years ago really pioneered the term microaggressions, and they developed these different themes of microaggressions, and then provided some examples of them, and then sort of the message that's being communicated by them. So I'll use one that comes up a lot, which is sort of the ascription of intelligence. So telling someone who is, for example, who's Black, saying, you're so articulate. That can be interpreted, or the message that could be sending, or what we call the meta communication, is that it's unusual for someone of your race to be intelligent. Or when you say, oh, my denials of individualized racism, so my best friend's Asian, what that might tell somebody is that I'm immune to being racist because I have friends of color, which is not true. Everyone, despite their experiences, can display characteristics or racist comments. One that's not on here is related to weight. So being overweight, So saying, wow, you're so brave to wear a bathing suit that might be, and that tells a person, oh, your body's not really good enough to wear that bathing suit, so you're really brave to put that on. And you'll see that these themes of marginalization on the left side are based upon appearance and denial of the history and systemic forces that privilege some and oppress others. And assumptions about people that erase their individuality and the diversity within our different racial, ethnic, sexual orientation, gender identity, and other characteristics. And what the literature has shown us is that these events happen time and time again. And in medical training, specifically in medical school, residency, fellowships, but it happens in the clinical environment all the time. Our patients can be the person who is saying the microaggressions to our staff, our nursing staff, our front desk staff. So the accumulation of these statements has impacts on everyone who's in those groups, including our learners. It contributes to decreased well-being and burnout. When we're negotiating our professional experiences while being othered. So we call that code switching. So you act a certain way in one situation and you act differently in another one. It creates a harsh learning environment and a harsh clinical environment that negatively can affect learning, performance, and wellness of our staff and our colleagues. And it has been linked directly to the development of depression, anxiety, and hypertension. So what I want to do is start by just giving an example of one of the microaggressions, and I'm going to walk you through this. Since usually I do this as a workshop for an hour and a half, but given our time limitations, I want to make sure we get through our content. But one of the common microaggressions that happens is when someone says, oh, you're so articulate. So I like to reframe them and help people understand how to break them. So the first thing is, what is this statement's intent? Well, the person who's saying the statement is trying to make a compliment and trying to praise somebody for doing something that they liked. Maybe they were explaining something to a patient in a way that was family-centered as pediatricians. So we talked a little bit about how this might be interpreted by the recipient, that the person who's saying this statement does not think that people who look like them can be articulate, or that's unusual for them to speak well. So we might be able to reframe the statement to match its intent, which is to give constructive and positive feedback by reframing it and focusing on the behavior. So for example, saying, I really liked how you explained the complicated diagnosis of juvenile idiopathic arthritis to this family who has limited English proficiency. Or I thought you did a really great job of responding to the patient's concerns and explaining our reasoning. So what that does is it tells the person who you're trying to say this to what behaviors you saw that you want to promote and have them continue, without it suggesting that you're surprised that they would be able to do that. So we've talked a lot about microaggressions. We've talked a lot about the definitions, the key players, our targets, our allies, our bystanders. We've talked about some of the themes that come into microaggressions, some examples of what might be said and how that might be communicated and what that might be communicating to the person who's receiving the microaggressions. So I want to spend the last half of the talk talking a little bit about how to respond to microaggressions in the clinical environment. This may be responding to a colleague, a trainee, or another clinical staff, or even a patient. So the first thing are some guiding principles. It's really challenging to respond to microaggressions when you haven't had any frameworks or practice doing it. The target may also not want you to, an ally or a bystander, to respond, because intervening may impact that own target's self-efficacy and autonomy, and they might want to respond themselves. So my tips are to pick your battles, pick where and when you're going to address the offender. So it may not be the best time to do it right in front of everybody. You may need to step aside, cool down a little bit, and pull them into a one-on-one conversation. And then adjust your response, confrontation versus educating the offender. As you're assessing the challenge, you have to always think about the power and hierarchy dynamics. So we have clinical hierarchies, we have, different people who have different levels of power. We're going back to the Hayes addressing framework. We have training hierarchies. We have patient versus provider hierarchies. And sometimes in group settings, so if you're on inpatient rounds, as I do as a hospitalist, it's oftentimes better to respond later, particularly if I'm in a position of relative power compared to the person who was the offender. But oftentimes the onus for responding to these falls on the target or the person who's getting microaggressed. So they have to assess their own energy to be able to respond. And these slides will be available to you. So I'm going to walk through them somewhat quickly, but I'm going to present 4 different frameworks for responding to microaggressions, and the articles that are cited in the slides have these laid out in more detail. But the first 2 frameworks are X, Y, and Z, and open the front door. And these are actually the ones that are easiest for me to remember. So X, Y, and Z is just, I feel or I felt X when Y because Z. So I felt uncomfortable when you said this statement because it made me think that you didn't think that I was intelligent. So it has the feeling, it has the Y, the X is the feeling, the Y is the situation or what happened, and then Z is explaining how it made them feel. The second one was the one that I tend to use the most, or the one that is easiest for me to remember, which is called open the front door. And the reason why it's easy for me to remember is because you're opening the front door into a larger conversation about the instance. So the O stands for observe, where you're making concrete objective statements about the microaggression. T is think. State your thoughts based upon that observation. F is feel, so state the emotion that you felt. And then D is the desired outcome. State what you want to happen at the end of this short conversation. So I'm going to present an example. This is going to be an example we're going to use throughout the last 15 minutes of this talk. So we're going to talk about a transgender patient who's admitted to an acute care ward that I would be the attending on for pneumonia with a large pleural effusion. And as the primary team is rounding, a consultant service interrupts rounds. And the consulting fellow misgenders the patient. And when the primary attending corrects the fellow becomes exasperated and says, ugh, it's another PC thing that I'm getting criticized for. So the microaggression is the consulting fellow misgendering the patient. And I, as the primary attending, feel like I need to respond to this fellow's microaggression to demonstrate to the team that that's not acceptable to do. So I'm going to walk you through the open the front door demonstration. Unfortunately, I call the fellow Dr. Russell because I don't like using other people's names when I'm accusing them of committing a microaggression. So the fellow is named Dr. Russell. So I might say, observe, hey, Dr. Russell, remember yesterday in the team meeting when you misgendered our mutual patient and sighed when I corrected you? So I observe, I state what the microaggression was. Then I think, so what do I think about that? So the think is your dismissal of our patient's wishes make me think that our hospital does not value the diversity of our patient population. Then I state my feeling. I wanted to share with you that I left that conversation feeling upset. And my desired outcome is I would like you to be aware of how reactions like that can have a negative impact, even though that probably wasn't your intent. So where would I do this conversation? Well, I probably wouldn't do it directly on rounds in front of the entire team, because that's probably not going to be a very viable time for that fellow to hear the feedback. So I want to find a time where it's, especially since there's a power dynamic, I am the attending giving this feedback to a clinical fellow who's not even in my division. So I would probably pull them aside and just have this conversation. 2 additional frameworks that we oftentimes will use are action, which is really more of a way to, it's sort of an expansion of open the front door, where we start by asking some clarifying questions. So assuming positive intent, trying to understand why they said what they said, really having curiosity as you're asking those questions. So trying not to display judgment. Then telling them the observation in an objective manner, so without a lot of emotion, and then stating the impact. So what is the potential effect that that microaggression has on others? So in this example, I might talk about, it also models that it's okay not to use our patient's, it's okay to misgender our patient, and that models that to our trainees who we're working with, and then other clinical staff. Then owning your own thoughts and feelings, which is just saying how it felt, and then next steps is the equivalent of desired outcome, so requesting that appropriate action to be taken. And then the final framework that we're going to talk about comes from Sue and his colleagues who developed and have really done a lot of the work around microaggressions, which is this micro-intervention, which is you make the invisible visible. So you actually just call out the microaggression and you say it very clearly. You disarm it. So you say, I don't agree with this. And that might happen with words, with body language. Then you seek to educate the offender and explain to them why the microaggression is wrong. And then depending on the level of that microaggression, you might also start to think a little bit about seeking external reinforcement or support. So depending on the level, we call them microaggressions, but sometimes these are just very overt racism or overt bias. And we have to sometimes use our reporting structures in order to mitigate some of the outcomes. So that might include reports to your Office of Diversity, Equity, Inclusion if you're in an academic center. It may be reporting to Title IX if you're in a university setting. But we're also seeking external reinforcements if you're noticing that the team or other people are struggling with how to really respond and to deal with the emotions that they're having. So it might be bringing in somebody to have a debriefing or a conversation about what's happening. And for those of us who are physicians who are leading practices or teams, you may be the person who has to lead those conversations. So it's not just, we don't always have access to other people who are able to help those debriefings. So we have to be comfortable with helping to lead those discussions. So I'll use the same example that we talked about earlier, and I'm going to demonstrate the micro-intervention demonstration, which the first step of that is making the invisible visible, which is stating what the microaggression is, and then stating what's wrong with it. So Dr. Russell, when you mentioned having to be politically correct, when I pointed out your misgendering of our patient, it suggests that the trans experience is abnormal. So in that statement, I've said, this is what you did, and this is what it suggests to me and the team. The next step is to disarm the microaggression right away. So I disagree that it is PC to address our patients as they request. At our hospital, all patients deserve the right to be addressed in a respectful manner. So I've disarmed it by saying, I disagree, stating what I disagree with, and then using hospital policies and sort of playing to their sense of morality and justice and respect. Then the third step is to educate the offender. So I would say transgender people have often experienced misgendering, which impacts their health. And then the fourth statement might be, I would seek external support. So so in this case, I'm probably not going to start by reporting this person to the Office of Diversity, Equity, and Inclusion or filing a professionalism report. If this has been a repeated instance, I might do that. So the external support might be saying, I'm happy to provide additional resources about this topic or arrange for a talk from our DEI office. So that is external support to help educate a person or a group in greater detail about this topic. So again, the steps for the micro intervention are to make it invisible, make the invisible visible, disarm it through language or body language or words, educate the offender about the situation, and then seek external support if you need it. So in terms of the ones that I often use, I find open the front door and micro interventions to be two of the ones that I'll go to. And they're related, but they're different. So micro interventions is a little more direct and it's a little more blunt. And so I might use that one when I'm talking to a colleague or when I'm fairly concerned about the behavior, or it's been something that's a little bit more repeated. Whereas open the front door is something that I often will use with a trainee, or I'll use in a time where it's a first instance and I think the person would benefit from a little bit more education. As I said it earlier, microaggressions are a really challenging topic, and they're really challenging to respond to, and they can really shake up a team. So I think it's important after you have, your team has experienced a microaggression, to really debrief with those who are involved outside the room. So for example, if a patient is the person who is the microaggressor, who is the, and then it's really important to, at the end of that, to take the team out of the room and talk about it. Talk to the target, acknowledge the event and everyone's discomfort with that event. So the first thing I'll say is often, when I heard the patient say the N-word, it really made me feel uncomfortable. And I can't imagine how it felt for all of you in the room, additionally, to hear the patient say that. How did others feel about that during the encounter? The team might need to debrief, talk about how they felt powerless to speak up. They felt uncomfortable in the situation, and they might feel uncomfortable moving forward, taking care of this patient. So really getting the feelings and acknowledging the discomfort around that room is really, really important, because if we don't do that, what happens is trainees or our clinical staff then really feel like it's okay for someone to do that and no one has my back and no one's going to speak up when it happens. So it's just going to continue to happen. And then remember, when we talked about the negative consequences, it's the anxiety, depression, high blood pressure that will develop, because these are, again, continuous things that are happening in Black, Indigenous, and other people of color's lives, and other groups that are in relative less power, including sexual orientation and gender identity. So I know I've talked a lot. I think I want to end with just a little bit of a summary, because we're getting into the last minute or two. So I really just want to remind people that to think about microaggressions based upon power differentials and differences in power. And really thinking about, as you're going into encounters with patients, with colleagues, and with trainees, in what ways do you as have relative power, and in what areas do you have relatively less power? So we are all as physicians, as pediatricians on this call, already have relative power compared to other people who we might be interacting with on a daily basis. And really think about those power differentials and how they might impact how both you interact with others, but also how others might interact with you. As I said, you should pick one or two frameworks to use consistently to respond to microaggressions that you might face or your staff might face. Because if you don't have a framework to respond, when it happens, you're not prepared. Just like if you hadn't, and then the third one is really practice responding to the microaggressions before having to actually do so in an encounter. So it really helps to practice this in a safer setting. Either we do role playing at CHLA where we have people actually do this and say this to each other to respond. It's just like a code event. If you don't have a mock code and practice it, and have a framework for how to address, life-threatening situations, when it happens, you're not able to respond. And with that, I just want to recognize some colleagues across the country who have really worked with me to help shape this talk and a lot of the work we're doing with respect to microaggressions. So Courtney Gilliam is a pediatric hospital medicine fellow at Seattle Children's, and Dr. Pat Poitevin, who is the residency program director at Hasbro Children's at Brown University. She's also the APPD, Association of Pediatric Program Directors President-elect, and both good friends of mine. And with that, I'm happy to take any questions at this time.
Thank you so much, Dr. Russell. There is a question in the Q&A, and I just want to remind all the participants that you can place your questions for Dr. Russell in Q&A. So the question, she says that she feels it was answered already.
I think we should still ask it.
Okay, so if a microaggression cannot be addressed in the moment, how do you ensure that other staff members, team members know the issue has been addressed or understand that it should be addressed?
Yeah, I think, so I partially answered that. That's why I wanted to answer it a little more. So I think the first step is to address it immediately outside the room. So that's how they understand that it should be addressed. So for example, I have that conversation with a nurse. If I'm working in an outpatient clinic and a nurse has experiences that, I pull her and the team aside and we talk about it right away. I think the challenge that you face is how do you ensure that the other staff know that it has been addressed when it's not done in the moment? So I think that's a tricky situation because we also want to make sure that we are respecting people's confidentiality. And so what I will often say is, I just wanted to circle back to some of the events that happened yesterday. I know that it was uncomfortable for everyone to see. I just wanted to let you know that I had a conversation about it with the person and was able to provide them with some feedback and resources. Or if it's a patient, I will tell the team very directly, I've addressed this with the patient and I said that this behavior is not acceptable. And if it continues to happen, then please let me know because we might have to escalate this. It's a really big challenge with patients and families, particularly in pediatrics, because in pediatrics, in adult medicine, they can sort of fire the patients, but in pediatrics, we have a dual responsibility to the patient and the family. So if it's a parent who is a person who is saying the bias or microaggressions, I can't just say to the family, I'm not taking care of the kid anymore. I have a responsibility to the child. So it's a little bit more complicated, but it still needs to be addressed.
And we have another question from Dr. Siegel. How do you deal with staff that do not modify their behavior after multiple attempts to address their continuing microaggressions?
So I think this is where it becomes, you go from curiosity to consequences. So I think it's important. I think we underutilize our reporting systems for professionalism. So at Children's Hospital Los Angeles, we have this thing called incident report or I-report, which is where you report patient safety things. But you also can report instances of unprofessional behavior. And it's very rarely used for that. It's usually utilized for, somebody raising their voice. But I think it's important to document these things so that there are potential, so it's documented so that if it is a pattern, you might have only experienced it once, but there's a pattern of behavior. And so, hospital medical staff offices, gather this information. So I would not only address it with the person, but I would also report it to the appropriate reporting structure. So that's in the micro intervention. That's the fourth one, get external help. So reporting an instance of microaggressions or other racist behavior can help create a document that allows them to see this as a repeated behavior, and then there will maybe consequences.
So there's also a question from Dr. Quo. Do these techniques also work for blatant aggressions, as
Yeah,
in not
they do.
microaggressions?
They do. I mean, the techniques should work for everything. I mean, I sort of don't like the term microaggressions because it at some level diminishes the impact that they have on people. But certainly, there's a really great article that I can put in the chat box. It's called "When the Patient Offends the Learner." It's in medical education, and I can provide it to you, Grant, or others. It's a really great resource that talks about not just microaggressions, but blatant bias and how you respond to it in the moment.
Yeah, that would be a really helpful resource because I feel like we were always taught in medical school to just ignore anything the patient does that's offensive or disturbing. And I think that this sheds some light on ways in which that's not the right approach.
Yeah, I think in fact that's the wrong approach because it reinforces the behavior, just like in children. Not addressing things can reinforce behavior.
Right. Yeah, and then so I like this. There's a question from Dr. Peralta that kind of flips the script, which is, what if you're the perceived microaggressor and you want to express your sincere intent not to offend anyone and you feel you were misinterpreted? How do you respond in that situation?
I'm going to stop sharing my slides just so I can see people. Sorry. Or I can see at least some people. Yeah, that's a really, really great question. How do you apologize? And how do you apologize authentically? I took that out of this talk because I had 30 minutes. But really, when you're thinking about apologizing, it comes to pulling that person aside, at least to start. You can also, and then expressing that the recognition that you recognize that what you had said was a microaggression or a potential bias, and then expressing your sincere apologies for that, and recognizing that's not what you wanted to do, but also thinking about how you might be working to educate yourself in order to ensure that you're learning more about this topic. I'm trying to find the slides as we're talking about this so I can pull it up specifically. There's a framework, it's called PAUSE. Here we go. Give me 1 second, because I think this is a really important question. And I can include this on the slide deck sort of as additional slides. So it's called PAUSE. That's the framework, sort of acknowledging, pausing before reacting, acknowledging the negative impact that it had on the person's life, understanding how and why it occurred, and then doing some self-reflection, and then embracing and exploring how you might be part of that change. So an example is, I was wondering if I could talk to you for a second. The other day, I confused you for Luis. So I confused two Hispanic men for each other. And I know that was a microaggression, and I've thought about it. I wanted to apologize to you. I know my words have an impact, and I'm sorry for that impact that it had on you. And I value our relationship and want you to know I'm aware of what I said. So I take responsibility, and I'm working on it. I think it's just really being just genuine and acknowledging that you did it, and then thinking about how you can, in the future, try to help stop it in the moment.
That's really helpful. I think we have very little time left, but I just wanted to quickly bring up this last question, which is, how about addressing microaggressions from superiors, either as a trainee or maybe as a physician in an academic institution? Yeah. Any tips?
Yeah, you have to know who are your allies. So finding those people. So if you're a trainee, talking to your program director, and if it's your program director, talking to the DIO, documenting them and reporting them through the reporting structure. So in most places, there's a reporting structure for bias events. Now, if we're in a small private practice, I understand that they don't have the same resources, but most healthcare systems have reporting for this. Or if there's an academic appointment and they have an academic affiliation, reporting it through that is another way. But I encourage you at minimum to document it and be very explicit about it, and then seek out your resources. Who are your allies? not just the bystanders we talked about, but who are the true allies who are going to help you make change.
Thank you so much. That was really helpful. I wish we had more time, but I think we have to move on to our business meeting.
Thank you so much for everyone's great questions, and please feel free to reach out to me offline if you want to hear more about this. I'm happy to talk more.